Hello everyone, myself Dr. Bhavik Champaneri. I'll be talking about cardiac emergency in pediatric practice. So I'll start with this slide. It's an old slide from 2005 Lancet article. So as you can see here, it's talking about causes of neonatal mortality, and as you can see here, these are the various common causes of neonatal mortality. Among that, preterm birth, sepsis, diarrhea, these are the most common causes of neonatal mortality when we are talking about neonatal mortality, which is more than 45 per 1000 live births. So as this neonatal mortality goes down and down, as you can see, as it reaches somewhere around less than 15 per 1000 live births, the causes which are important for neonatal mortality. So the congenital cause, as you can see with this purple color bar, this purple color bar is going up. So the congenital causes or the congenital defect becomes the second most common cause of neonatal mortality as we reach to the neonatal mortality rate of less than 15 per 1000 live births. So when we are talking about congenital defects, congenital heart disease is the most common congenital heart defect in newborn, which accounts for 25% of patients. At least 25% of this CHD are life threatening, which is called critical CHD, and deaths due to CHD is of higher importance for improvement in perinatal care. Birth prevalence, when we are talking, so the congenital heart disease prevalence is 8 to 12 per 1000 live births. Children born with CHD, so according to this prevalence rate, if we calculate the number of children being born with congenital heart disease, it will come to the number of 2,40,000 children are being born every year in India with congenital heart disease. And when we are talking about incidence of critical congenital heart disease, out of this 2,40,000, nearly 50,000 kids are having critical congenital heart disease. That means if we are not identifying these kids or children or neonates in a timely frame, we may be losing these kids because of lack of treatment provided to them. So coming to neonatal cardiac emergencies, when we are talking about heart disease in neonate, it may present as hypoxia or cyanosis, it can present as heart failure or shock, it can present as arrhythmias, or it can present as murmurs. So talking about classification and its various presentation, duct dependent systemic circulation, coarctation, aortic valve stenosis, congenital AV valve regurgitation, myocardial dysfunction, various rhythm disorders may present as heart failure or shock. These are the various diseases like duct dependent pulmonary circulation, detransposition of great arteries, obstructed total anomalous pulmonary venous connection. They may present with cyanosis or hypoxia. So these are the cyanotic lesions, among which most critical is the duct dependent pulmonary circulation. So these are the various list of duct dependent pulmonary circulation, which can include pulmonary atresia with intact ventricular septum, pulmonary atresia with VSD, severe form of tetralogy of Fallot, critical pulmonary stenosis, Epstein's anomaly of tricuspid valve, where there can be a functional pulmonary atresia. So these are the examples of duct dependent pulmonary circulation. Duct dependent pulmonary circulation, again there is a range from extreme variety to milder form of duct dependent pulmonary circulation. In extreme form or the most darkest form is called pulmonary atresia, where the presentation is very drastic. It's absolutely duct dependent. As duct closes, patient will present with severe cyanosis, acidosis, and will become very sick early. And when we are talking about milder variety of duct dependent pulmonary circulation, the example can be pulmonary stenosis. Again, it's not absolutely duct dependent because there is some degree of antegrade flow across pulmonary valve, so they may be relatively duct dependent. Once duct closes, there may be varying degree of cyanosis depending on the degree of pulmonary stenosis, and presentation is again determined by severity of pulmonary stenosis. These are diagrammatic pictures of pulmonary atresias. This is a normal heart. This is an example of pulmonary atresia with VSD, which is called tetralogy of Fallot with pulmonary atresia, where there is a ventricular septal defect, no pulmonary artery is formed, and this pulmonary arterial blood flow is absolutely dependent on this ductus arteriosus. This is an example of pulmonary atresia without VSD, where there is no VSD. Often these patients have hypoplastic right ventricle, there is no antegrade flow going into pulmonary artery, and this pulmonary arterial blood flow is dependent on ductus arteriosus. So another example of cyanotic congenital heart disease include TGA, this is normal heart, while here aorta is arising from morphological right ventricle and pulmonary artery is arising from left ventricle. So there is a parallel circulation. So deoxygenated blood coming from the body is again going back into aorta, while oxygenated blood which is coming from pulmonary artery is coming to left ventricle and again going to pulmonary artery. So it's a parallel circulation, and again saturation is often dependent on the level of admixture at the level of atrial septal defect. So if ASD is adequate, these patients may be relative, they will be cyanotic but less cyanotic. If the ASD is small, they will be extremely cyanotic and acidotic. This is an example, these are example of TAPVC. This is an example of obstructed supracardiac TAPVC. As you can see, pulmonary veins are forming a common chamber which is draining through ascending vertical vein, as you can see here, into innominate vein, and this ascending vertical vein is having a stenosis. So that's why this is an example of obstructed supracardiac TAPVC. This is an example where pulmonary venous confluence is formed through descending vertical vein. It's going into liver parenchyma or portal vein, and then it's coming into IVC, and at the level of diaphragm or at the level of liver parenchyma, this vertical vein gets stenotic, and often infracardiac TAPVC is an example of obstructed TAPVC. When you don't have any obstruction, these patients are relatively less cyanotic, and they are not actually an emergency, and they can undergo elective cardiac surgery at around 1.5 to 2 months of age. Talking about examples of duct dependent systemic circulation: hypoplastic left heart syndrome, critical aortic stenosis, aortic arch interruption, or severe coarctation of aorta. These are various examples of duct dependent systemic circulation. So here the systemic circulation is dependent on duct. So if this duct closes, this patient will go into cardiogenic shock with liver and hypoperfusion of liver, renal and abdominal organs, and giving rise to multi-organ dysfunction like liver failure, renal failure and all. So again, duct dependent systemic circulation is also a variety from ranging from extreme cases like HLHS and interrupted aortic arch, where the systemic circulation is absolutely dependent on ductus arteriosus, and once this ductus closes, this patient will go into shock, circulatory failure, renal failure, liver failure. While milder variant can be aortic stenosis and coarctation, where again it may be relatively duct dependent, and once duct closes, there may be varying of presentation depending on how severe the lesion or the disease is, and heart failure will develop after duct closes. That again will be dependent on the severity of the lesion. This is an example of absolute duct dependent systemic circulation. This is an example of hypoplastic left heart syndrome. As you can see, left ventricle is hypoplastic, aorta is hypoplastic, mitral valve is hypoplastic, and the DTA or the systemic circulation is absolutely dependent on this PDA. Once this PDA closes, the blood flow into aorta is compromised, giving rise to systemic shock or the cardiogenic shock. This is an example of interrupted aortic arch, where you can see after particular one point there is no continuation with the descending thoracic aorta, and this descending thoracic aorta blood is absolutely dependent on this PDA, and once this PDA closes, it will go into systemic shock. So this is very important. Prostaglandin infusion is life saving. So everyone should be aware about prostaglandin infusion. In any duct dependent condition, either it is systemic or it is pulmonary, prostaglandin works wonder. Prostaglandin is life saving. Immediately it opens PDA, and it will provide alternative blood supply to the necessary organs. It's usually started in the dose of 0.04 to 0.2 microgram per kg per minute, and once ductal patency is achieved, it can be reduced down to 0.01 microgram per kg per minute. Here we are not targeting saturation to be in the range of 90s or above 95 and 100. Our aim is to maintain saturation somewhere around 80 to 90 or more than 80% with PO2 of around 45-50, and main target is to have normalized pH. Talking about management of pediatric cardiac emergency, it can be transcatheter as well as surgical. So these are example of transcatheter management. This is a TGA with restrictive PFO, which can be palliated with balloon atrial septostomy for a while till he becomes fit for surgery. Critical aortic stenosis and can undergo balloon aortic valvotomy. Pulmonary stenosis can undergo pulmonary valvotomy. Pulmonary atresia with intact IVS can go pulmonary valve perforation with balloon dilatation, and if needed can undergo PDA stenting in addition. Duct dependent pulmonary circulation can be stented. PDA can be stented with the stent, and we can maintain the patency of PDA, and we can stop prostaglandin infusion. Talking about surgical management, there can be complete repair in case of arterial switch operation. In case of TGA, it can be arterial switch operation. In case of TAPVC, we can repair TAPVC. Coectation, arch repair, these are all complete surgical repair. While certain cases like duct dependent pulmonary circulation, where we want an alternative pulmonary blood flow, they can be palliated with BT shunt or Norwood surgery in form of in case of HLHS or hypoplastic left heart syndrome. So I'll go through few case examples which will explain pediatric cardiac emergencies in a better way. So talking about neonatal cases, this is a full term CS delivered male child whose weight is 2.8 kilo, and he is admitted in NICU for respiratory distress syndrome, but after 48 hours or 24 hours of management, there is no change in chest X-ray, and this is an X-ray. You can see it's a diffuse pulmonary venous congestion. You can see it obviously looks like RDS, but there is no improvement after classical management of RDS, and pulmonary venous hypertension or pulmonary venous congestion persists, which will give rise to the appearance of whiteout lung. So this was a case of obstructed infracardiac TAPVC. As you can see in echo, this is a descending vertical vein venous channel, which is draining into liver parenchyma, and then it goes through IVC into RA. So it's an obstructed infracardiac TAPVC. This is a diagrammatic presentation of obstructed infracardiac TAPVC. Further course, patient was shifted at our institute on 3rd day of life. He underwent emergency TAPVC repair. He had an ICU stay of 7 days. Was discharged on 15 days, has been on regular yearly follow-up, and has been doing well. So what is important in this case? He was diagnosed in a timely manner. Before he decompensated, he was shifted at our institute in a timely manner. He underwent, because he was fit for surgery, he underwent emergency surgery, and because everything went so smooth, he had hospital stay of nearly 15 days only. So that is very important when we are talking about pediatric cardiac emergency. The time of diagnosis and referral is very important. This is a second case. It's a full term normal delivered male, 3.3 kilo, had severe cyanosis, 50 to 60% acidosis, and at birth only he is referred for further management. And this is an X-ray. As you can see, there is a narrow pedicle at the of heart, and the classic X-ray of agon side appearance. So this was a case of transposition of great arteries with intact ventricular septum, but he had a restrictive PFO, and that's why he was very blue, because there was no mixing of blood happening at level of atrium. So this patient underwent emergency balloon atrial septostomy at our institute. SpO2 improved to 80%. By 10 days of life, patient underwent arterial switch operation and was sent home on 25th day of life. So this is third case. This is very important. It's important to diagnose the congenital critical diseases in timely manner, and this case shows that how important it is. So it's a 7-day-old female child. Child was stable, so patient was sent home on 3rd day of life, but on 4th or 5th day, patient was admitted in ICU with severe respiratory distress and was ventilated. On examination, the child does not have femoral pulses, there is no urine output. Create has gone up to 2.5, SGPT, SGOT both are elevated. Echo was done and it detected severe left ventricle as well as right ventricular dysfunction. There was a critical coectation of aorta, no PDA. Bicuspid aortic valve, but no aortic stenosis or aortic regurgitation. So this is a case where the patient is compromised, patient is not fit. The ideal plan is to send this patient for coectation repair, but he is not fit. He has come in a vegetative state. His RFTs are deranged, his LFT is deranged. So this patient was taken for balloon dilatation of coectation of aorta. Since it was critical coectation, femoral arterial access was not successful and patient underwent through right axillary access. This is an angio. You can see it's a critical post subclavian coectation of aorta, and patient underwent balloon dilatation of coectation, and this is a post procedure angio showing well open coectation of aorta. So Renal and liver parameters improved over a period of 7 days, was extubated on 3rd day post procedure, remained in hospital for 15 days and has been on regular follow up till now. So this was a case, if this case patient was diagnosed in a timely manner, we could have salvaged this patient from decompensation, and we could have provided treatment in a timely manner. So this is a 4th case. It's a 25-day-old male child, weight is 4 kilo. He is very blue and has been detected to have murmur by pediatrician. SpO2 is around 80%. Echocardiography diagnosed that it's a critical valvular PS, gradient was 110, significant right ventricular hypertrophy with hypoplastic right ventricle, RV dysfunction is there, PFO is exclusively right to left, and there is a small PDA with severe tricuspid regurgitation. So patient was taken for balloon pulmonary valvotomy. This is a balloon being inflated, and as you can see, post balloon angio, RV is so hypoplastic. So this RV is not able to accept the preload of RA. It's the preload, the blood from RA. That's why PFO is shunting right to left. So this pulmonary blood flow may not be adequate for these patients, and they may remain still blue because there is less amount of blood reaching into pulmonary artery circulation because of small RV, and that's why this patient underwent PDA stenting in addition to balloon pulmonary valvotomy, which improved his saturation to around 90-95%, and over a period of time, because we have established a good antegrade flow across pulmonary artery, this RV will grow over a period of time, and patient may reach to 2 ventricle stage level or at least 1.5 ventricle repair level. So these were the cases of neonatal emergency. I will go through few pediatric emergencies. This is a 3-month-old male child who has presented to casualty at morning 7 a.m. with complaint of excessive crying, significant bluish discoloration, fast breathing. There is no history of fever, vomiting or diarrhea. Child is very irritable. He is weighing 4 kg, severe cyanosis, SpO2 is 60%, S2 is single and very faint ejection systolic murmur is heard on left second intercostal space. So what are we dealing? So very likely we are dealing with a physiology of spell, cyanotic spell. So what is cyanotic spell? So it's basically sudden decrease in pulmonary blood flow, which will give rise to excessive right to left shunting across VSD and give rise to a series of events, and a series of events which will eventually lead to severe cyanosis and breathing difficulty and distress and severe acidosis. So patient was detected, he was already a case of tetralogy of Fallot. Emergency IV access was taken, normal saline bolus at 10 ml per kg was given, oxygen at 5 liter per minute was started, child was placed in knee chest position. So what is the role of fluid bolus? So basically it increases the preload to RV. So it will increase the RV volume, which will reduce the infundibular spasm, and thus it increases the pulmonary blood flow. And how knee chest position helps? So you can see knee chest position will compress the the aorta as well as IVC. So if when it compresses the aorta, it increases the systemic vascular resistance, it increases the blood pressure and decreases the right to left shunting across the VSD. When we compress the IVC, it will reduce the more deoxygenated blood from lower limb will not reach to the right ventricle, which will prevent stimulation of respiratory centers and which will break the cycle of cyanotic spell. Further course, patient was given morphine 0.1 mg per kg IV over 1 minute. So how morphine helps? It provides analgesia, it provides sedation, it reduces sympathetic stimulation as well. What are alternative to morphine? You can give ketamine because at the dose of 1 mg per kg it provides sedation. In addition, it increases SVR as well. Patient still continued to have spells. So NS bolus, repeat NS bolus was given and patient was started on metoprolol 0.1 mg per kg over 10 minutes, and repeat dose of metoprolol was given over after 10 minutes. So how beta blocker helps? It reduces the heart rate, it reduces the infundibular contraction or spasm, and there is some reduction in sympathetic stimulation. What are alternative to metoprolol? It can be propranolol or ismolol. So after this, ABG of the patient was done, and bicarb was around 10 and HB was 10 grams. So based on this ABG report, what is the precipitating factor in our case? Very likely it's anemia. So how anemia affects and precipitates cyanotic spell? It reduces the oxygen carrying capacity. In addition, it reduces systemic vascular resistance as well. What are other precipitating factors for cyanotic spell? It can be infection or fever which reduces the SVR. It can be diarrhea, vomiting which causes hypovolemia and causes vigorous infundibular spasm and development of cyanotic spell. So bicarb was given to our patient, and Pexel was given at the dose of 15 ml per kg IV over 4 hours. Child improved over a period of time, SpO2 improved to 85%, ejection systolic murmur became more louder, diagnosis was confirmed to have tetralogy of Fallot, but child was 4-month old and patient became stable. So patient was managed medically, medication was optimized, patient was discharged on second day of admission on iron drops and propranolol, and at 6 months of age patient underwent complete cardiac repair. Post-op period was uneventful and patient has been doing well. This is the second case. It's a 12-year-old boy, 35 kilo, has complaint of palpitation since last 4 hours. There is a complaint of giddiness and increased neck pulsation. So this is an ECG showing heart rate of somewhere around 180 to 190 per minute. And you can see QRS. Each QRS is being followed by a retrograde P wave. So we are dealing with a tachycardia, which is a short RP tachycardia. So what was done? Immediately IV access was taken and adenosine at a dose of 0.1 mg per kg with rapid flush technique was given. And this is an adenosine ECG. With dose of adenosine, tachycardia terminated with the QRS, and eventually it converted into a sinus rhythm. So very likely we are dealing with a case of AVRT or AVNRT. Patient was started on oral metoprolol at 1 mg per kg twice daily, and patient was discharged home. And eventually patient will undergo radiofrequency ablation and with EP study. So when we are talking about pediatric cardiac emergency, with development of newer and more advancement in intensive care in NICU, in PICU, we come across very frequently, sometimes we come across cases where the pediatric cardiac emergency is created because of some other reason. So this is an example. It's a 4-day-old neonate. He is very low birth weight, 32 weeks of gestation, and birth weight is 1.2 kilo. Had a peak line from saphenous vein, but this peak line got fractured and embolized to heart and was referred to UNMICRC hospital for further management. So this is an fluoro image. You can see the peak line migrated and fractured and embolized into heart and protruding into right ventricle and left pulmonary artery. This is a lateral projection. You can see the peak line projected into embolized into right ventricle and left pulmonary artery. So patient was taken to cath lab and the peak line was taken out, and this is the final last fluoro showing no residual fragment left behind in the heart. So this is a published case report by our center. This was a peak line which was taken out of the very low birth weight child who was weighing 1.2 kilo. So key points. We should always have a high index of clinical suspicion to enable early diagnosis and early referral of these patients with pediatric cardiac critical diseases. Prior stabilization and monitored transport to tertiary center ensures optimal preoperative state. Understanding the physiology is very important in the management of critical congenital heart disease. Early intervention is realistic for most forms of critical congenital heart disease, and it's very important to know that majority of critical CHDs have near normal life expectancy after its management is done. Thank you.